Our next guest is now Andri Rauch, and he will talk about a monitoring center concept for HIV, viral hepatitis, and STIs. He will talk about how the incidence with HIV are declining, but still too many new infections are happening. And that also in Switzerland, for example, 2023, over 300 people have been newly infected. Where and how do these transmissions occur, and what is the impact of campaigns on behavior? These are some of the topics he will touch. Andri Rauch is the head of the infectious disease department of the Inselspital in Bern. His primary focus is the clinical work and improvement of treatment of viral infections, such as HIV and viral hepatitis. His field of research is to enhance the efficiency of antiviral therapies, as well as improvement of care for people living with HIV or viral hepatitis. He is the president-elect of Swiss HIV cohort study. I got it. Thank you very much.
Thank you so much. It's a really kind introduction. And thanks for the invitation. Great to be here to share with you some thoughts of a monitoring center for HIV and hepatitis. Many of those in the room know that this is not a really new concept. We have been discussing this since many years, maybe for too long. Maybe we should realize it now. But we have been discussing it for many years. With many stakeholders, and I think I want to share today the idea of such a monitoring center, because I'm convinced that by doing this, by optimizing surveillance response, we could really have a nice tool towards eliminating HIV, STIs, hepatitis, which would not cost too much. We could do it if we wanted it in Switzerland with not too much costs, and then we would have a great tool at hand. I think Marcel has already touched upon it, and I'll try to share with you some of the ideas that we gathered, and I'm of course very grateful for input after in the discussion or at a coffee break, how we could really realize this in the next years to come. Okay, let's start with the elimination targets for HIV. I start with HIV because the concept that we originally established was thought for HIV, but then I'll show you that we also extended it for STIs and for hepatitis C. You know all these elimination targets expressed by WHO, UNAIDS. It's really, I think, a great document. You all know the 95-95-95 rule. The 95% of persons with HIV should be diagnosed, 95% treated, and 95% have a suppressed HIV viral load. But the new UNAIDS, the goals agenda, also include many other targets, for example, reducing stigma, reducing discrimination, equal access to care, gender equality. So I think all this bundled together is very well summarized in the WHO, UNAIDS documents. And if this was achieved, we could reach, I don't know if this works here or here. Well, you can see it. Can I show it here with the mouse maybe? Got das Ding da, oder? Ah, here. Ah, yeah, you can see it. If this would be achieved, all these targets would be achieved, diagnosed, suppressed, then we would see a large reduction in new the diagnosis of HIV until 2030, and we would really achieve the elimination targets, which is expressed by UNAIDS as not more than 300,000 new infections per year. That would be here. So where are we there worldwide with regard to HIV? We have seen in 22 still 1.3 new diagnoses, new HIV infections. This would be the target for 25. So you see there is decline, it's good, but we're quite way off target. So if we want to achieve the WHO goals, we are still quite, there has been a lot of improvement, but we're still quite a lot off target to achieve this reduction of 90% and to be at this 300,000 worldwide new diagnosis, new HIV diagnosis worldwide. And it's a similar situation in Switzerland. You might have seen the FOPH bulletin recently, and you can see, of course, there has been a big reduction since the 1990s, but then it's kind of a flat line. We've still seen 370 new infections in 23, and if we want to achieve the WHO targets, we should be about at 50 by 2030. So, I mean, it's good, it's not increasing, but it's a flat line. We're not going really towards elimination with regard to HIV. And you also know that very well for hepatitis C. There also we have seen a certain decline, but it's also that we still see new infections. We probably do not diagnose enough infections, and the elimination targets are still not achieved as well for hepatitis C with regard to new diagnosis in Switzerland. So, for the situation of HIV, we're clearly not on target, despite all this progress that we have seen. U equals U. So in Switzerland, more than 95% have been diagnosed, more than 95% have treated, more than 95% have a suppressed HIV infection. So we have achieved that, but despite that, we do not achieve the elimination targets, even not in Switzerland, despite all the resources that we have. We have PrEP now, very efficient way to prevent infections. We have near perfect with regard to hepatitis C. We have near perfect DA treatments. We have a very dense health coverage. We have a well-established Meldewesen from the FOPH where we report all new infections. We have intensive monitoring. For example, in the Swiss HIV course study, Swiss prepared, we have a lot of good tools, but we do not achieve elimination targets in the time frame that we should. My 2030s at the doorsteps, we are not really on target with that. So of course there's many reasons for this, but what I want to show you now is how we could improve surveillance response. How could this be a tool to be better in achieving elimination targets to really reduce infections for HIV or for hepatitis. And I'm convinced that we have all elements in Switzerland. So we have a lot of fantastic tools in Switzerland for a great surveillance response system. So we have, for example, the checkpoints with the Burda data where we record a lot of infections electronically in this system. We have the Swiss HIV court study where we have fantastic data on HIV, on suppression, on treatments and so on. We have Swiss Prepared where many persons receiving PrEP have been included. We have the Meldewesen. We have, of course, Hepatitis Schweiz. We have done a lot of efforts in it. We have the network of the FMA, AIDS-Hilfe Schweiz, Bundesamt für Statistik. We have a lot of stakeholders, of organizations who do a great work, but this work and this data that we gather in all these organizations is not sufficiently linked. And that's a pity, because by linking this, we could do much better. And I'll show you now a few examples, mainly from the Swiss HIV court study, how having a good surveillance system really can be useful to respond, surveillance and then respond, and then to really have an impact on the number of infections that you see in a population. This is a study which is now already 12 years old by Gilles Wandel from our center, who has observed in 2010, around 2010, this increase in the incidence of hepatitis C infections among men who have sex with men. For many years, we had not seen that in hepatitis C virus infections in men of sex with men, and we observed this increase here, which was really surprising to us. We did not expect that at that time. But because we have seen that, we have observed that, and we have really noticed that before the FOPH has seen that in their data, because we have seen that, we could intensify monitoring, and we could then also establish the so-called HCV-free study by Jan Fehr and colleagues, Dominic Brown, many others have been involved in this, where we have seen, okay, there is a problem, then we have determined HCV RNA in all persons with HIV in the cohort, and we offer treatment in all these individuals, and we really have seen a large drop in incidence of hepatitis C virus infections in this population. Of course, it's not a huge number, it's not a huge population, it's a very well followed population, it's an optimal scenario to achieve elimination, but still, by detecting it, having a surveillance, offering treatment, you can really achieve elimination. So surveillance response really can have an impact. That's another example for syphilis. We have very good data on syphilis in the Swiss HIV core study, but we have also this data from the FOPH, and Suraj Balakrishnan and colleagues have looked at it, and they have seen they described the incidence of syphilis among men of sex with men in persons with and without HIV. And when we saw this, we noticed, okay, we have to do something. And the model that Suraj has developed indicated that one of the best tools is to increase screening frequency in these high-risk populations. And by having this data, we could have a response. Surveillance led to a response, which in this case meant more frequent screening to bring down the incidence of syphilis. This is an example from, with regard to behavior. It's kind of a very colorful slide, but it's a nice example how powerful this data can be to describe certain trends. This is a study by Luisa Salazar-Vizcaja, who has used the data from the VCTs, it's collected in the BERDA system, and looked how does behavior change overall, and by using artificial intelligence methods, can we identify certain groups. And I only want to point to this example here. For example, partners who met online, so online dating, you see the overall trend here is in gray over years. So you think there is a certain decline, but overall it's kind of stable. But if you look then at certain groups, you will see that certain persons have a very high incidence of this behavior, and other groups have a low but increasing trend in behavior. So in using this data and in using artificial intelligence, you can find groups with different behaviors that you can again target for your interventions. So again, the power of using data of surveillance to have an impact on certain behaviors. This is an example how phylogenetic data, so this is data derived from sequencing virus, can be used to identify transmission chains. An example from the group of Roger Cuyos, who has also already talked at this conference, was analyzed a lot of sequences of HIV and could then identify transmission chains, and can then describe how these transmission chains evolve over time. So for example, here in these red ones here, these red ones here, this is quite a big cluster that evolved after 2019. And you can now imagine, if you have this data, you can identify these clusters, you can go there, you can intervene, you can really have an impact in bringing down the incidence. So these tools that we have, phylogenetic analysis to identify transmission chains, can have an impact on reducing incidence for HIV. We have done something similar for hepatitis C. This is again a study by Luisa Salazar-Vizcaya, where she has done this beautiful phylogenetic tree, and she tried to find out where did these infections occur. And she found some clusters, some clusters which were only built by persons within Switzerland. These were transmissions which occurred in Switzerland, and other clusters which were composed of infections in Switzerland together with European infections, or here, for example, with German infections. And you can then understand much better how these transmission events occur, and you can intervene. Either you have to intervene in Switzerland, or you have to intervene on the international level. So by understanding these transmission events, you can have an impact in responding. How can you interrupt these transmission events? Okay, so these were some examples of the literature that we have seen, how powerful these tools can be. And here I want to summarize how an optimal surveillance response could be for preventing HIV transmissions. We have the whole time frame from exposure to infection to treatment to occurring of disease. In Switzerland, we have monitored, or at least we could have monitored it in Switzerland. So from time of exposure, we have the VCTs, the Volunteer Council and the testing centers, where many persons with a certain risk behavior have a test. We have the visits, we have a test, and we know if the test was negative or positive. We have Swiss Prepared, where we have a lot of persons at high risk, where we have the information on risk behavior, on infections, and so on. Then we have the HIV diagnosis, which is then recorded in the Meldewesen. And after diagnosis, we have the court network, where we have a very dense follow-up, where we have a lot of information on the infections, how it's treated, how disease progression is, and so on. The problem is that these data sets are not connected. So we have information in VCTs, we have the information in Meldewesen, we have information on the core network, but there is a gap in this information system. So we do not really know we cannot follow persons at risk at diagnosis, after diagnosis. That's one of the problems. And the second problem that we have is that not all persons living with HIV are in the network, are included in the Swiss HIV cohort study. Not all want to participate. Not all centers are included. So it's still about 20% of persons where we do not have this data here, and that's a clear gap. So we have a gap in the surveillance system in Switzerland. So how could this be improved? And we could improve this by having a monitoring center. And a monitoring center would essentially be a center where all this data would be collected together, and very, very essential would be that we have a unique identifier. We will need an identifier which identifies persons who are in this network, in this network, and in this network, that we could identify this is the same person. This can be done with different methods, probabilistic linkage methods. Maybe with the new Epidemiengesetz, if we get the AHV number, the social security number, this would be a tool. But by linking all this data together, we would have all this data together in one data set, and we would have much better data on behavior, on sexual transmitted infections, on disease progression and so on. And the beauty of this thing is we would not have to gather new data. No new data lab analysis would have been done. It's all just a question of linking all this data which is already there. And this was the monitoring center for HIV, which we discussed for many years. And then in the frame of discussions with Swiss Hepatitis or with the discussion of NAPS, the new program, we also said, well, this could be applied exactly the same also for viral hepatitis and for STI. As you know, this is also an important part of the new NAPS to eliminate HIV, hepatitis, and STI. It's in one program, and you could have essentially the same center, the same system with the unique identifier. Of course, you have to increase the stakeholders. You could have, for example, data from the Swiss transplant, from the Swiss transplant cohort study, from the microbiological laboratories, from SAMSU, for example, and you could gather all this data, collect it together with one unique identifier, and we would have a fantastic tool for surveillance, which will really boost surveillance response in Switzerland. I'm really convinced of that. And this is a slide that was already shown by Marcel before, and it's also something that Marcel told me many times until I was really convinced that it's true. It's important to have minimal essential data. I come from a Swiss HIV course study, and we're a bit spoiled. We always want to collect everything, because we do research and everything is important. But for elimination, for surveillance response, you don't need all this. You need a minimal essential data set, and this data set is not huge. So you need a little bit of demographics, of behavioral characteristics, basics on health. So you need to know if there are hospitalizations, if somebody is on treatment or not. And you need lab results, and lab results not only from persons who are in the cohorts, but from all persons. But all this data is there. The labs collect all this data. They report it even to FOPH. All the diagnosis of hepatitis, it's all reported, and what is not reported could be reported. It's all there. You just have to link it. And yeah, I think it's obvious, but I hope one day we'll have it. This summarizes the sources that are there, and if there is data in the Meldewesen, there's a lot of data in the Meldewesen. The problem is it's not linked to the other stakeholders. There is a lot of data in the SHS network, Swiss prepared Perda data, SAMSU. In the clinics, there is a lot of data around, but it's not linked. We cannot link the data together to have a comprehensive data set on all these infections. And now we are asked many times by the FOPH and others, now what is the added value of such a monitoring center? It's very nice to have all this data, and we try to summarize it. To me, the added value is huge. You can have all data for prevention behavior. You can see, as I've shown you before, how behavior changes. We have this data. We collect it every day in the VCTs. We just have to use it and to act on it. You can see in which groups does behavior change, how can we react to it. And we can also measure this. What is the impact of all these interventions that we do? What is the impact of campaigns? If we have this data, we can use it to have a measurement of the campaigns. We can have very precise estimates where infections occur. I've shown you the phylogenetic studies. We can know quite quickly where do these transmission chains start, and if we interrupt there, we can prevent a lot of infections. That's true for HIV, for hepatitis, for STIs, it's all the same. We can, if you could link Swiss Prepared better to the HIV, we could know much better how why did PrEP not work to prevent HIV infections? Where are the gaps in PrEP? Where are the gaps in the HIV cascade? We know the gap in the HIV cascade very well in the court, but for all those persons who are not in the court, we don't know. And we could know that by collecting this minimal essential data. We could measure to which extent treatment uptake and efficacy differ in person within and without and outside the court. This would be interesting, not for research only, but especially also for public health. Where do we have to invest? And for hepatitis and STI, the situation is very similar. We could know much better where and when do these infections occur, what are transmissions, and how are these transmissions also linked. We know from the Meldewesen there is an infection here, hepatitis C infection, there is there hepatitis B infection, there is there a gonorrhea, there is there a HIV infection, but we even don't know if this occurred in the same person. We don't know who has repeated infections. For syphilis, for example, is very important. For hepatitis C, we have also reinfections. We don't know that from the Meldewesen. We do not know how are the complications of viral hepatitis occurring. There's also an important elimination target. In whom does liver cirrhosis occur? In whom is fibrosis progressing? In whom does it not? This data is there, at least in part there, in the hospital systems or in the Bundesamt für Statistik and in other sources, but it's not really collected well enough that you can react upon. And of course, I try to convince you that this unique identifier would be really a great tool to link all this data together, HIV, hepatitis, STIs, with not much effort. It would not cost too much to do this, and I hope we can. I hope I could convince you, but we also hope that we can convince the FOPH and all the stakeholders, and that will have this fantastic surveillance response system next year. We're now trying to get it since many years. I hope next year will be the year. We'll see. Thanks a lot.
Thank you very much. Thank you so much. If there, we are a little behind schedule. Is there a question, an important question right now? Then we could maybe take it now. Yes?
Thank you, Andri. Two quick questions. In your opinion, what's the main stumbling block on the way to implementing this? And the second one, what's the price tag attached to it?
So the stumbling block to me is the unique identifier. So we need a unique identifier, and there needs a political will, and there needs an effort from the FOPH in the end. The FOPH, the legal responsibles of this have to decide it's okay to have it. If we have once Epidemiengesetz with AFA number, that's good, that's perfect. But there are also ways to link this data. There have been studies, you have probabilistic linkage. It can be done. Price tag is cheap. I guess it's below 1 million per year, which is not a lot seeing what we spend otherwise. Yeah.
Okay.
500,000 is also good already.
Another question? Okay, so thank you very, very much for coming. It was very interesting.